Okay, Assalamualaikum warahmatullahi wabarakatuh and very good afternoon to all of the participants for this GP ENT webinar 2021. First of all, I would like to thank the organizer for this event, Malaysian Society of Otorhinolaryngology and Head and Neck Surgery. I'm Dr. Salman bin Amruddin, ENT from University Sultan Zainal Abidin, and in this session, I will share about allergic rhinitis versus chronic rhinosinusitis. What is the difference between these two types of disease? And I believe that these two diseases is commonly encountered during our clinical practice. As an introduction, sinusitis is a common health problem characterized by mucosal inflammation of the paranasal sinuses, and is often coexists with rhinitis in most of the patient. So it further divided into two subtypes, which is acute and chronic, based on the duration of the symptoms. It has an important risk factor, which is smoking, family history of chronic rhinosinusitis, asthma, and gastroesophageal reflux disease. For allergic rhinitis, they divided the symptoms which suggest of allergic rhinitis and the symptom which is not associated with allergic rhinitis in the area guideline 2008. Area guideline is a allergic rhinitis impact on asthma, which is a guideline that further elaborate on allergic rhinitis symptoms. The first one is the symptoms that suggest of allergic rhinitis. If the patient have two or more of the following symptoms for more than 1 hour in most of the day, which is watery rhinorrhea, sneezing, nasal obstruction, and nasal pleuritis associated with conjunctivitis, we can classify or clinically diagnose this patient as allergic rhinitis. However, if the patient have unilateral symptoms and nasal obstruction without other symptoms, mucopollular rhinorrhea, posterior rhinorrhea with thick mucus without anterior rhinorrhea, okay, it may be associated with anterior rhinorrhea, and also pain, recurrent epistaxis, and anosmia, we have to rule out another disease that involve the nasal cavity. In 2020, to 29 to 2019, okay, so the allergic rhinitis is further classified into the severity of the disease. So in mild type, it usually the patient the daily activity of the patient is not disturbed. They will have a normal sleep, normal work and school, no disturbing symptoms. However, in moderate and severe, they will have disturbed sleep and also later on the problem during works and school, and they will impact their daily activities. For symptoms, intermittent symptoms means that the patient have the symptoms of less than 4 weeks per day, 4 days per week, or 4 weeks per episode. And for persistent symptoms, the patient will have more than 4 days per week or 4 weeks per episode. Chronic sinusitis has an additional symptoms on top of the allergic rhinitis symptoms. So patient might have also the nasal blockage, congestion, or nasal discharge. However, in chronic sinusitis, they will have facial pain. Sometimes will have frontal headache, and reduction of the loss of smell. And for chronic sinusitis, also they need to have an endoscopic sign of nasal polyp, mucopurulent discharge, which is primarily from middle meatus, and edema or mucosal obstruction, which is happen in middle meatus. And in this type of patient, if we do CT scan, they can see the mucosal changes within the osteometal complex or within the sinuses itself. For the diagnosis, as recommended in CPG, Clinical Practice Guideline of rhinosinusitis, anterior rhinoscopy should be performed as a part of clinical assessment if we suspect the patient have acute rhinosinusitis in primary care setting. Okay, if we refer the patient to ENT clinic, okay, so they have to do nasal endoscopy to diagnose the rhinosinusitis. So this is anti-rhinoscopy that has been done using tudicum speculum. So anti-rhinoscopy is aimed to visualize the anterior part of the nostril. So by doing this procedure, we can see if there is any abnormalities uh, pertaining to the septum, or if there is a mass that fill up the nasal cavity. We also can see, and we can differentiate between this mass from the hypertrophy of the inferior turbinate. For nasal endoscopy, it is done using a rigid endoscope. So this instrument will be inserted along the nasal floor until to the level of nasopharynx. So by doing this procedure, we can see clearly the nasal cavity from anterior part to the posterior part. For example, this is the view of nasal endoscopy. We can see clearly the inferior turbinate, we can see the middle turbinate, and also the space between the inferior turbinate and middle turbinate, which is osteomeatal complex. And in this area, usually if there is any polyp or any mucopurulent discharge, this area will be affected. So we can see up to the posterior part of the nose, which is nasopharynx. We can differentiate whether if there is any obstruction for the posterior choana that may be due to mass that arise from nasopharynx. And by using this nasal endoscopy, also we can do a procedure maybe to take a biopsy if we suspect the patient having uh, a mass that causing nasal obstruction. Okay, for CT scan, paranasal sinus, if the patient that we suspect to have chronic rhinosinusitis, and we give treatment for 48 hours, okay, however, there is no improvement, or the patient that presented with complication uh, from the sinusitis, such as orbital complication or intracranial complication. So we must do CT scan, and this is as a plan or the initial step to plan for a surgery to remove the source of infection from the um, sinus that affected with the bacteria. Okay, so for laboratory tests, nasal swab shouldn't be performed in rhinosinusitis. So it is a clinical diagnosis. If we see there is a mucopurulent discharge from OMC, osteomeatal complex, so we straight away we can diagnose this patient as rhinosinusitis. So nasal swab is not an obligatory procedure. However, if there is no response to antibiotic after 72 hours, so we can perform nasal swab, which we obtain from middle meatus, or we call it endoscopically directed middle meatus culture. Okay, so we can differentiate the type of allergic rhinitis from rhinosinusitis by looking at the nature of the nasal discharge. Okay, in allergic rhinitis, the nasal discharge is clear, watery and clear. In rhinosinusitis, it could be purulent. In allergic fungal rhinosinusitis is mucin nasal discharge. In allergic rhinitis, facial pain, uh, patient doesn't complain of nasal pain. However, in rhinosinusitis, patient will complain of facial fullness, okay, and frontal headache, okay, and in allergic rhinitis, usually is associated with nasal itchiness. Right. So in rhinosinusitis, uh, patient doesn't complain of these symptoms. Okay, for sneezing, okay, allergic rhinitis, a patient will have sneezing. In rhinosinusitis, most of the symptom is nasal obstruction. Okay, if we encounter of this type of complaint from the patient, okay, which is nasal obstruction, purulent, greenish nasal discharge, facial pain, headache, and some smell disturbances, so we have to do anterior rhinoscopy, at least to have a look at the anterior part of the nose. Okay, and then if there is nothing we suspect, um, except allergic rhinitis itself. So we can give the patient topical steroid and nasal irrigation, and we can add on antihistamine. Okay, so we can re-evaluate after 4 weeks. Okay, if the symptom is not improved, so we can refer to ORS specialist. They will do the further investigation, such as nasal endoscopy and skin prick test to detect whether the patient have allergy to certain allergen, and also they can consider another diagnosis Okay, and they will add on the treatment such as short-term oral steroid and also oral antibiotic. Okay, if there is an improvement, so they will continue all the medication for at least 1 month. And if there is no improvement of the symptom, they will do the CT scan to look at the paranasal sinuses and consider to do endoscopic sinus surgery to remove the source of infection within the sinuses. Okay, and after that, they will continue the follow-up with ORL center. For antibiotics, it's mentioned in CPG that antibiotic may be prescribed in acute bacterial rhinosinusitis after weighing benefits against potential side effect. Okay, so the preferred antibiotic is amoxicillin, 500 mg 8 hourly for 5 or 7 days, or augmentin, 6 to 5 milligram 8 hourly for 5 to 7 days. And antibiotics should not be used routinely in chronic rhinosinusitis. So it's just used in acute bacterial rhinosinusitis. For intranasal corticosteroid should be considered for 14 to 21 days in acute rhinosinusitis, and it should be given more than that, up to 52 weeks in chronic rhinosinusitis. So for short-term oral corticosteroid, only given in chronic rhinosinusitis at otorhinolaryngology center. For antihistamine, we will prescribe in rhinosinusitis if it is associated with symptoms suggestive of allergic rhinitis. So if the patient previously have the symptom of sneezing, nasal itchiness, nasal obstruction, and rhinorrhea, we will give the antihistamine to this patient. And also saline irrigation or alkaline nasal douching should be used as an adjunct therapy in patient with rhinosinusitis. Nasal decongestant, the topical decongestant should not be prescribed for more than 2 weeks because we're afraid of a rebound phenomenon. Okay, so we have to differentiate which type of the nasal steroid, nasal spray that have decongestant or nasal spray that just have low dose steroid. And the oral decongestant should be cautiously prescribed in those with medical condition such as diabetic mellitus, cardiovascular disease, glaucoma, and benign prostate hyperplasia. So as a summary, we give antibiotic in an acute bacterial rhinosinusitis, okay, and topical steroid mostly in all type of rhinitis. Additional of topical corticosteroid to antibiotic just in acute bacterial rhinosinusitis. Oral corticosteroid also for acute bacterial rhinosinusitis, saline irrigation for all type of rhinitis, antihistamine, analgesic, and decongestant. Usually we give when the patient have allergic symptoms. Oral antihistamine, okay, yes, we give in allergic patient. And for paracetamol and decongestant, we can prescribe for the patient, especially in viral and post-viral acute rhinosinusitis, and mucolytics doesn't need in the patient of rhinosinusitis. What is the indication for referral to ORL center? Some of the patient came at the later stage, so they came with complication. Okay, so if we see the patient with periorbital edema, which means that the infection already extend to the orbital cavity, or the patient have double vision, ophthalmoplegia, restricted eye movement, so all the symptom of eye following the nasal symptoms. So we have to refer the patient urgently to ENT because maybe they need to further evaluate by a nasal endoscopy and CT scan, and plan for sinus surgery. And if the patient have severe frontal headache, forehead swelling, and also neurological manifestation, we suspect the infection already extend to the intracranially. Okay, so we have to also to refer urgently. Okay, but if the patient have frequent symptoms, we suspect it's malignant, or the patient have persistent symptom despite of optimal therapy. So this patient need early referral at least within 2 weeks. Okay, I think that's all for my part. So I hope we can differentiate between allergic rhinitis and rhinosinusitis, and what is the difference of management investigation and management for these two type of disease. So I hope this will benefit our clinical practice later on. Thank you.